Thank you for the kind introduction. It's a privilege to be here. I hope those on Zoom or WebEx can hear me all right. So a couple of key thank yous before I get started. First, to Dr. Polsani and the entire group at Piedmont. It's a real privilege and honor to be here in this amazing Heart Institute. I want to congratulate you on what you've all collectively built here, and it's been a privilege also to work with you and collaborate with you on a number of projects that I look forward to seeing to completion and publishing with you. And I want to thank Chick-fil-A for sponsoring this morning's discussion on atherosclerosis. It's grateful. I appreciate the business and yeah, no, joking. But that is a good way to segue. What I'll share with you is my passion around cardiac CT. With that passion perhaps comes with a lot of energy. I try not to take myself too seriously. I'm very open to criticism and comment, but I hope that my arguments and my discussion evokes at least interest and internal discussion at this great Heart Institute. I do have disclosures. So over the next 45 minutes or so, I'm going to try to go over why the chest pain guidelines were updated and brought forward CT as a first-line test, why the chest pain guidelines from the ACC gave a Class 1 level of evidence A designation, and really try to prove why CT can continue to grow and how it will continue to grow to help answer questions as it relates to the field of cardiovascular medicine. So as mentioned, October 26, 2021, probably the fifth most important day in my life after my wedding day and the birth of my three children, I guess my birthday, so sixth. The ACC came out with new chest pain guidelines. And again, they provided a Class 1 level of evidence A designation for CT because it diagnoses coronary disease, it stratifies risk, and it guides treatment decision making. So you may say to yourself, okay, well, where's the evidence to support that? And let's just walk through that. To me, ultimately, as an imager, I work in service of the patient and obviously the referring clinician. And to me, when we're selecting a test, we really should select the test that answers the question at hand. And fundamentally, I believe that when a patient presents with new onset symptoms suggestive of possible CAD, in the absence of previously documented coronary disease, I believe, in fact, that the patient wants to know if he or she has coronary disease and how extensive and severe is it. And fundamentally, I believe that the nurse practitioner, the general practitioner, or the cardiologist has wanted to answer that question, but has not been able to answer it non-invasively up until recently. And I say that because if you look at the traditional workup and management of patients with symptoms and not yet confirmed coronary disease, it's fundamentally flawed as it relates to answering that question, right? It starts with an adjudication of symptoms that is, as I like to highlight, culturally, gender, sex, ethnically, and climactically biased, right? I mean, you look at the graphical display of typical angina, and it's always an older white male clutching his chest in a snowstorm, which is obviously not that relevant here in Atlanta for a whole bunch of reasons, given the diversity of the population, and you're going to be waiting a long time for a snowstorm, I would imagine. Then you, of course, auscultate the chest because that's very helpful in diagnosing LAD stenosis, and then you use non-invasive stress testing. And tongue-in-cheek, non-invasive stress testing will continue to play an important role in clinical cardiology, absolutely. They answer important questions, but they fundamentally don't answer whether the patient does or doesn't have coronary disease, whether or not they have atherosclerosis or stenosis, right? If you want to do a stress CMR to look for peri-infarct ischemia, or if you want to look for microvascular dysfunction with PET, or if you want to look for regional wall motion abnormality on a stress echo, great. But if you want to know if there's an LAD lesion, those tests don't do a very good job. How can I say that? Well, there's work from Duke back over 12 years ago from Manesh Patel and Pam Douglas showing that almost 65% of patients who went to the cath lab in this great country were not found to have actionable coronary disease. And what was interesting at the time, and I see Dr. Kanzari has joined, and I remember, probably doesn't remember me from 20 years ago back at Duke, but I remember when Manesh published this work that the lay press was just castigating the poor interventionalists. How can you be cathing all of these people? You guys are cath happy. But how is it the interventionalist's fault if she doesn't find actionable coronary disease if you refer a patient with chest pain and a positive stress test? It's clearly not the interventionalist's fault. It's a limitation of the pathway. And so when I used to share these data, many of my colleagues would say, okay, that's great, Jonathan, but your test is too sensitive. You identify this atherosclerosis stuff, which I don't know, I didn't think it was inappropriate to actually identify as the disease that causes infarction. But many argued in the early days that I just want to make sure that the patient doesn't have critical disease. And so if we look at Dan Berman's data, this is old data, but it held true in the Ischemia trial as well. 101 patients with left main adjudicated stenosis at the time of the cath that had undergone non-invasive stress testing before, 44% had normal or mildly abnormal stress tests. So that is tremendous diagnostic uncertainty. The only way you can feel confident that your patient doesn't have left main disease after a normal SPECT is the fact that left main disease is just not common, but not because the test actually helped you identify it or rule it out. So why CT? I think the first reason the guideline shifted to support CT class 1 level of evidence A is the anatomical accuracy. Now, it clearly doesn't have the spatial resolution of cath. It's not meant to replace cath. It doesn't have the temporal resolution of cath. But as a non-invasive tool, there is no better test to exclude coronary disease or confirm the presence of an anatomical stenosis. I could share with you endless accuracy trials dating back to 2008 and beyond, but these are data that come from the Ischemia Core Lab, for which I also served, and my colleague Joe Mancini. Looking at our role again in the Core Lab was to exclude left main disease and diagnose anatomical stenosis. And the agreement with the QCA Core Lab was 97.1%. Not perfect agreement, but incredible anatomical detail allowing you to confidently exclude left main disease and confirm that the patient has a stenosis in their coronary tree of at least 50%. No test can even approach that remotely as it relates to anatomy. Now, as mentioned, we know fundamentally that left main disease is important to identify. I certainly, even as an imager, can appreciate that. And if you look at the modern guidelines, and I didn't want to cast too much aspersion to the stress testing pathway, but the stress testing pathway that remains open is a bit confounding to me because it suggests that if you have a non-evaluable stress test, you should consider cath. Okay, that doesn't make sense to me. You order a test, and if it's a non-diagnostic, that's when you go to an invasive procedure. But if you have a mildly, moderately, or severely abnormal stress test, the guidelines suggest put them on guideline-directed medical therapy. Okay, but in the ischemia trial, amongst patients with moderate to severely abnormal stress tests, 7% had left main disease. So how do you go home to your, to go to bed at night knowing that you're putting the patient on medicine without knowledge that they have left main disease or not? And so many within the ischemia trial said, okay, well, maybe we can identify clinical predictors, maybe features of the stress test that could allow us to derive a model for the identification of left main disease in the setting of an abnormal stress test, because then we could at least, better understand which patient should proceed for invasive angiography. And the conclusion from this very elaborate analysis was to exclude left main disease in patients with abnormal or moderate to severely abnormal stress tests. Anatomical imaging is required. So if you want to rule out left main disease before the initiation of medical therapy, you cannot simply squint and look at the stress test in a different way. You can't add a whole bunch of clinical variables to really determine who those patients are. You need to do a CT. Now, how about CT to guide ICA? This is a very important trial published out of Europe in the New England Journal of Medicine, 3,500 patients, a CT-guided cath approach versus a direct-to-cath or stress testing to cath approach. And not wanting to delve too deeply into it, I think what we learned from the study was that a CT-guided approach was not only safe, it enriched ICA referral such that the PCI to ICA ratio was 58%, compared to a direct or stress test to cath approach where it was 18%. And at 4 years, the primary outcome of MACE was there was equipoise between these two approaches. This is also even historic data, and I think missing a new opportunity not only to decide the decision around of whether to go to the cath lab, but also the opportunities to actually explore these data to inform revascularization, which we'll touch upon. So the second reason is that the CT was elevated is, I think, because it provides rich prognostic data that extends beyond traditional stress testing. Again, 15, 16 years ago, when we were doing CTs, people would say, well, that's a great diagnostic tool, but I need to do a stress test to understand the risk of the patient, which of course seemed a little bit funny to me because, I'm sure we would all agree it's not a surprise that the extent and severity of anatomical disease would connote increased risk of death and MACE. I mean, this is what we've known from the 70s. But what we see here from CT is that it's not only a powerful prognostic tool, but it's far more powerful than traditional stress testing. This is a sub-analysis of the PROMISE trial, published in 2015 in the New England Journal. This was published in Circulation. 10,000 Americans randomized between CT versus stress testing. X-axis is time, Y-axis is the percentage of patients with events. Let's look at the two lowest curves. Patients with a negative SPECT had a 2.5 times higher event rate than a negative CT. So the negative likelihood ratio, or the warranty of a negative CT, is much more profound in its risk reduction than a negative SPECT. This ignores the warranty period. We know that a negative CT has a warranty of 5, 7, perhaps 10 years. A negative SPECT usually falls down, at least in Dan Berman's lab, at about 1.5 years. So you're less likely to have events, and the warranty with which you can have that confidence extends much longer. How about someone with a mildly abnormal CT? You know, in the confirmed registry, which we contributed, people said that the event rate that we saw in those with plaque but without stenosis was ascertainment bias because it was observational data. Well, it turns out that the relative risk of a mildly abnormal CT in the PROMISE trial was exactly the same as what we found in the 27,000 patients in the confirmed registry, 3-fold higher risk. An absolute risk with non-obstructive disease that is still not through the roof, but it really allows you to discriminate between those two patients as to their personalized risk. You have plaque, your risk is elevated compared to those without plaque. Let's have a conversation around medical therapy. Therein lies the opportunity of CT. On the other hand, a mildly abnormal SPECT and a normal SPECT, the exact same downstream outcome. You have two patients waiting to see you in the clinic. One has a mildly abnormal test, one has a normal test. I would think that they would be having that conversation saying, I guess with my test being abnormal, our doc's going to treat me differently because I have an abnormal test. Turns out you have no evidence, at least from PROMISE and from many other studies, to titrate medical therapy based on those results, of course. You reflect back on population-based risk factors. Whereas in CT, you can actually have a conversation with a patient about their personalized atherosclerotic burden and their potential benefit of medical therapy. Last thing, severely abnormal CT, 10-fold higher event rate compared to those with a negative CT. Relative risk of a severely abnormal SPECT, 4-fold. Why is that? Because the absolute event rate of a negative SPECT is not as low as a negative CT, but in addition, as we saw in the Ischemia trial, if you have a severely abnormal stress test, 18% of those patients were not found to have a stenosis greater than 50% by our CT core lab. So they were excluded from the trial. So when you have a severely abnormal SPECT, you can tell your patient, you either have severe coronary disease or you have mild coronary disease. Just the same way when you have a mildly abnormal or normal SPECT, you can tell your patient you do or you do not have left main disease. How about mortality? This is from Harmony Reynolds from the Ischemia trial. The extent and severity of anatomical disease exhibited a dose-response relationship with mortality. Again, probably not surprising to, I won't pick on Dr. Kenzari, but the other interventionalists. This is, he didn't wake up early to hear that. He's known this from the interventional world for many, many years, but we find the same thing from CT, right? If you have more severe anatomical disease, you're more likely to die. What CT can also offer us, though, is, of course, atherosclerosis. Now, not with the image fidelity or spatial resolution of IVUS, but it allows us to identify the number of lesions, whether the lesions are calcified or not, whether they have positive remodeling or low-density plaque, and perhaps in the future, we may have an opportunity to actually quantify plaque in a fashion that we can track treatment outcomes. So what do we know about this atherosclerosis that we've identified? Well, we know, as mentioned previously, that the extent and severity of plaque on CT exhibits an important prognostic signal as it relates to downstream MACE. The number of vessels, the number of segments, the overall visual burden of plaque helps us identify patients at risk beyond the focality of diameter stenosis. This holds true not only in the confirmed registry, but also in the West Danish Heart Registry. Even a crude measure, they looked at downstream prognosis as it relates to stenosis, which was obviously a powerful predictor, but then even the calcium score in an untreated non-statin taking population provides a crude but reasonable overall assessment of plaque burden. Plaque burden seems to be predictive even beyond the focality of disease. What about lesion characterization? This was seminal work from Jaga Narula and Sadako Motoyama 13 years ago, highlighting that the very same features shown by our colleagues in IVUS may help us identify patients at risk beyond anatomical stenosis. Positive remodeling and low-density plaque exhibited, when present, two-feature positivity, exhibited a relative risk of 44-fold. So when I read those data, the questions that continue to flow through my mind, and we shared last night in conversation, is which is it? Is it the totality of plaque, or is it the morphology of plaque? Is it this, in fact, low-density plaque, or is low-density plaque just, does it just go along with patients with more plaque burden? Because, when we reflect on this incredibly important data, one thing that I didn't appreciate at the time is they adjusted for the severity of anatomical stenosis, but they had no mechanism of adjusting for the totality of plaque. So adverse plaque is predictive over and above stenosis, but is it predictive over and above the totality of plaque? Similarly, within the ICONIC registry, we matched patients within the confirmed registry who had infarction and those who did not, and found, using elaborate core lab quantitation of atherosclerosis, that patients who experienced infarction had a more fibrofatty and more necrotic core. So again, does this mean that somehow it's the morphology of the plaque that trumps the totality of plaque? But again, if you look carefully at the ICONIC registry, you can see the very unfortunate mistake that we made, and we thought this was the appropriate design, which was, of course, to match patients based on age and sex, site, cardiovascular risk, and even quantitative plaque burden based on CT quantitation. But in retrospect, this was a real mistake because we lost the opportunity to really explore between these two important variables, the totality of plaque versus the morphology of plaque, as to which is the most dominant in the predicting of risk. But I do think that going forward, we'll continue to explore this question as a field using advanced tools to really continue to build out this message. Which is more important? Is it the focality of disease as it relates to stenosis? Is it the focality of the morphology of the plaque? Or is it the totality of plaque? So why would we even want to pursue quantitation of plaque if calcium scoring is quite a reasonable surrogate? I think the one reason to consider it is to also explore treatment response and also mechanisms of MI. So I think we would all agree that plaque progression is a needed step prior to MI. And I shared last night this beautiful figure from Jagged and from Amir Ahmadi from Mount Sinai that I think very elegantly opens the eyes of so many as it relates to connecting the very seminal work from people like Dr. Ambrose and others around non-obstructive disease causing incident MI and the reality at the time of the MI, right? If we look at the left, these are all the studies that looked at angiography prior to MI, and from which this mantra that non-obstructive disease causes MI really emanated. But when you look at these studies, most are very small studies, 10, 15 patients, and the incident MI was anywhere from 10 to 40 months after the baseline angiogram. So my interpretation of those data as a trainee was always, I conflated those results to mean that mild lesions on angiography were the drivers of incident MI, when of course we don't know what happened to those lesions between the time of the baseline angiogram and 15 months later or 40 months later, as we saw in Prospect. All we can tell is that when we actually do intravascular imaging at the time of the infarction, or if the patient should die and the patient's heart goes to Professor Vermani, the culprit is almost always a bulky, ugly, sinister lesion, bulky in size and stenotic. So the message here, of course, is not that non-obstructive disease is more sinister than severe stenosis. If it was, obviously the cath labs would be taking a very different approach. But the message is that non-obstructive disease should not be ignored. That if left unchecked in some patient, it exposes them to a risk of progression and incident myocardial infarction. And therein creates an opportunity for us to use CT as a tool to guide medical therapy and perhaps as a tool to understand progression. We don't have evidence yet, but perhaps. We do have some evidence that shows that progression is a strong predictor of MI. These are data from Korea, also data from a registry we participated in called Paradigm, that patients who had progressive atherosclerosis on serial CT were much more likely to experience myocardial infarction. So I think as a non-invasive tool, not only to diagnose atherosclerosis, not only to potentially quantify atherosclerosis and characterize it, but in the future to understand treatment response is an exciting opportunity for great institutions like this to explore mechanisms of MI and opportunities to enhance treatment decision making. Now, everything I've shared with you to date is very rosy, but I would highlight that if we do this, that we really, as imagers like Dr. Pulsani and myself, we need to support reproducible acquisition such that these quantitative tools can be applied in a thoughtful way. This is an analysis done by a former fellow of ours in Vancouver, Hide Takagi from Japan, and he looked at the paradigm data set, and not to physics nerd out on you guys, but just to highlight that if you simply change the scan parameters on the CT between 100 and 120 kVp or 80 and 120 kVp, so the energy changes. When you change the energy, it has a direct and indirect effect on plaque composition. You can drive the calcium up or reduce the overall calcium burden. The point of this is to highlight if we ever do get the evidence to pursue serial CT, if we do this, we really as a field need to make sure we do it thoughtfully and make sure that our changes in protocols or changes in image reconstruction don't create spurious effects that mislead us in the field. The third reason CT was brought forward is because I think it guides clinical decision making in a fashion that improves outcomes. So people may say, well, how do I know that? I think there are a number of important studies that have highlighted that. This comes from the West Danish Heart Registry, where every patient who undergoes cardiac testing is entered into a database. And what you can see here is that patients who are treated on the basis of CT had a 30% lower MI rate than those patients treated on the basis of rubidium PET. Not SPECT, but rubidium PET. How is this? It's of course not the radiation from CT that stabilizes plaque, but it's rather that it provides you personalized information about the extent and severity of plaque that allows you to appropriately revascularize and appropriately titrate medical therapy. We saw the same thing not in an observational trial, but in a randomized trial from Scott Hart. Scott Hart randomized 4,000 Scots men and women between traditional care and CT. The CT arm exhibited a 40% lower cardiovascular death and MI rate. And again, why is this? Because it allows for personalization of medical therapy and shared decision making. You know, if I go back to my medical training, what was I was taught? If Dr. Pulsani told me as a patient to take medicine and I elected not to follow his recommendations, what did you call me? Non-compliant. I mean, if that isn't paternalistic, culturally, probably sex-based paternalism in so many ways, right? What we should be doing is having shared decision-making with our patients as to why, right? If our patients aren't motivated to engage with us in our therapeutic recommendations, perhaps it's that we haven't provided them the evidence. But what we see here with Scott Hart and PROMISE is that when you tell a patient, not that you're at a population-based risk of having disease, and they come from a population that is underrepresented in the very databases that you're looking, and you expect them to be excited by that, right? They say, Doc, I'm from Thailand. How many Thai people were in this registry you speak of? Well, I don't know, and probably not many. How is that? Versus if you tell them actually, you know, you have coronary disease. I don't know you're going to have a heart attack, but I know you've already exhibited that you have the disease that could cause downstream heart attacks. And these are the tools we have, you know, risk factor modification and medical therapy. So the final thing I wanted to close on, though, is this last question, which is, should we revascularize a patient? And obviously, this discussion becomes more and more complicated and nuanced over the years as we've seen an evolution of data. But I think we would all agree that the totality of randomized evidence to date doesn't support urgent revascularization on the basis of anatomy alone, right? That we identify an LAD lesion, and before we could extract physiology, we're left with uncertainty as to how we should proceed. And we've also seen growing data, though, that physiology is a Class 1A tool to really guide those decisions. That patients with abnormal physiology derive benefit from revascularization, and patients with physiology in the above 0.8 by hyperemic physiology derive harm from revascularization, at least in this database from Ontario. And while there's powerful information from physiology, it's always been limited by the invasive nature. that you expose the patient to a risk of coronary complication, perhaps 3% from invasive angiography and FFR, only to tell the patient that your FFR is negative, you don't need to be stented, but hopefully you didn't experience a complication. So about 12 years ago, I first heard of this technology, which I know you use clinically here as well. The concept of taking a resting CT and applying artificial intelligence and machine learning, as well as computational fluid dynamics, to derive a hyperemic pressure model that correlates and agrees with invasive FFR to a high degree and exhibits high diagnostic accuracy. Now, when we talk about this tool, wow, I don't know what that did to my slide. It changed the text. But either way, it was provided a Class 2A indication for stable and acute chest pain to complement CT in the setting of a patient and a lesion that you would consider for revascularization in an anatomical range between 40 and 90%. So why did the guidelines give a 2A support? The first reason is that the tool is reproducible, and I think the second is that it's accurate. Again, not perfect, not exhibiting perfect agreement or accuracy with invasive FFR, but an accuracy about 86, 87%, and a kappa agreement of about 0.82. And why do I mention the kappa agreement? Well, if we look at the Pacific trial, what we see here is that the accuracy of FFR-CT compared to invasive FFR is superior to other tools, even oxygen-labeled water PET read by Juhani Kanuti in a core lab. But beyond that, I think what is exciting most to me about this pathway is that it's a combined anatomy and physiology. And if we look at the guidelines say that we should consider doing this when we identify a stenosis that we would consider for revasc. At that point, I don't think our interventionalists want to know, is there a flow disturbance in the LAD? Or is there a perfusion abnormality in the LAD? My interventionalist wants to know, where is the lesion? How long is the lesion? What is the pressure? What is the phenotype of the physiology? Is it a focal phenotype or a diffuse phenotype? And how deeply abnormal is the pressure loss? And PET, of course, can't provide you that because it doesn't provide you with lesion localization, nor the depth of the physiology, nor an absolute number. So how has this impacted clinical decision-making? Well, we've seen a lot of observational data that have highlighted, including a very large registry called ADVANCE, that it enriches cath lab referral. It enriches cath lab referral over and above CT alone, and certainly over and above stress testing alone. It does so in two ways. One, by capturing patients who are missed by traditional non-invasive stress tests. We've seen that as we saw in Danny CAD 2 presented at ESC, that stress CMR and PET, in this case rubidium, had a sensitivity of abnormal physiology of 40 to 50%. So you miss people with non-invasive stress tests. And it also does so by avoiding unnecessary cath in patients with stenosis, but negative FFR-CT. So in other words, you have an anatomical narrowing, but the physiology is normal. Those patients don't need to go to the cath lab. Well, how do we know it's safe? This is from Manesh Patel, the one-year outcome data of ADVANCE. 1,700 patients with a stenosis, negative FFR-CT at 1 year, event rate very low, and the revasc rate only 5% at 1 year. So I think we have growing evidence that deferral of invasive angiography in the setting of a stenosis and negative FFR-CT is safe. The patients get good symptom relief on medicine alone, and they're exposed to a low incident MACE rate. This holds true not only at 1 year, but these are data under review, and I believe in JACC imaging, but were presented at ESC from the West Danish Heart Registry. 1,000 patients followed for 3 years, and you can see that the prognostic utility of CT extends out to 3 years and is incremental to stenosis and calcium score. If you have a stenosis and a calcium score over 300, which is the cut point they use, and the FFR-CT is negative, your event rate is very low. But importantly, if you have abnormal FFR-CT, you're not only at a hazard of increased urgent revascularization, but actually increased risk of death and spontaneous MI. And what they showed was what we've seen in the invasive world from Niels Johnson and many others, is that the depth of the FFR also exhibits a relationship, so that the lower the FFR-CT, the greater the risk beyond that. So it's for this observational data and growing prognostic data that FFR-CT is not only in the guidelines, but also in the CADRADS 2.0 document. Again, not to be mandated that you need to do it, but that if you identify a patient where revascularization or additional testing is being considered in the setting of a 40 to 90% stenosis, that FFR-CT provides complementary physiological information that can guide decisions around invasive angiography and beyond. Now, everything I've shared with you is observational. There is a randomized trial, Precise, that was led by Pam Douglas from Duke, and I know your site was an enrolling site in this, and the data has been submitted for presentation at AHA. I don't know if the formal acceptances have gone out, but I certainly look forward to the results of the study, a randomized trial of 2,100 patients to really understand how this pathway compares to traditional care. But importantly, it had a sub-randomization of testing versus no testing in those that were deemed to be lowest risk by the PROMIS risk score. So I'm equally excited by that, because I think in this modern day, we really need evidence to really identify patients who don't need any testing, because I'm very sensitive to over-testing and cost, and then choose the right test for the right patient when there will be benefit. Finally, I wanted to close, and I'm grateful that there's some interventionalists still in the room, that I think that because I know your cardiac CT program has really grown, and I think going forward we're going to see more and more interventionalists grabbing hold of this data and engaging with it and owning it, the way we've seen in TAVR, right? As I always tease, when I came to St. Paul's as a junior staff, John Webb was already doing TAVR, having done the first transarterial TAVR, and he said, he uses 2D echo, and I said, 2D echo, when I do these CTs, it looks like an elliptical structure. It seems very limited. And he said, Jonathan, in the early days, I gave a woman a small valve and a man a big valve, and that was his only way of discriminating how to size. So he was pleased with 2D echo. But of course, now, if I asked you, how often do you do a TAVR without a CT? It's pretty rare, right? And yet far too often patients still go to the cath lab based on this Procan paradigm or algorithm, and our interventionalists cath themselves and mutter under the cath. They hopefully don't cath themselves, they cath the patient and mutter under their breath, Pulsani fooled me again. He sent me a patient that has no coronary disease. I just radiated myself and the patient, and all this expense, and what a waste. Or perhaps worse yet, an indeterminate stress test, and then you identify the most sinister coronary disease you've seen in 4 years, and you don't have 20 years as an interventionalist, and you've got a non-STEMI waiting for you, and you make ad hoc decisions about revascularization, and then we wonder why 40 to 60% of patients are incompletely revascularized, which we know is associated with a worsened outcome, not only of late revascularization, but also about a 35% increased risk of MI. The reason this is okay, maybe some patients can't be completely revascularized, but I would also argue it's because we've failed to provide our interventionalists with adequate information prior to their procedure. This is the only invasive procedure in all of medicine where our poor interventional colleagues go to the cath lab completely uninformed. They do an invasive procedure to rule out disease. Right? Can you imagine now when you emerge here, someone going in to take out an appendix without documenting that they had appendicitis, or going to do an EVAR, I'm going to do an endovascular aortic aneurysm repair, but I don't know if they have an aneurysm? So I think CT can provide you rich information when it's being used just part of the workup, and then our interventional colleagues do what they did, work alongside people like Dr. Pulsani, and learn how to use this information to enrich your cath decision making. One way is to provide fluoroscopic angles. This is from Nico Piazza and a group from Krakow, showing that you can personalize not only the root of the aorta or the mitral annulus if you're doing a TIMVR, but what about the left main and the left main bifurcation to optimize your invasive approach? You could do this using virtual, volume rendered images or FFRCT models. And there's a very nice example of this from Carlos Colette. This is his typical working angle. He explored the CT. He realized that RAO cranial would be a much better angle in this case. And the lesion was in fact over 1 centimeter longer than had he used the traditional working angle. Now, sure, OCT or IVUS could have told you the lesion was longer. But again, I'm not saying to replace that, but you have the CT. It's now just a matter of exploring it. How about lesion preparation? Heavily calcified lesions, challenge for anatomical diameter reduction. But how about to inform the likelihood that you may need to do lesion prep with either lithotripsy or rotablation? Informing the consent of the patient. Look, you have very calcified lesion, we may need to do this, we may not, but you have this information for free prior to the cath. How about plaque morphology beyond this? This is a case from my friend Abdullah Dahid from Perth. He was with us in Vancouver. Extensively non-calcified plaque in the LAD, the invasive angiogram. He poses the question. I couldn't get radial access, so I certainly am not the one to answer what to do. But he would posit to us that in this case, a patient who had exertional angina, a calcium score of 0, and severe proximal LA disease, that the plaque components, the tremendous burden of non-calcified plaque, the risk of no reflow and periprocedural MI, the large burden of non-calcified plaque extending into the left main, as you can see, the acute angulation and the requirements for a two-stent strategy. For him, this was informative and helped him over and above the invasive angiogram to guide towards CABG. How about avoiding unpleasant surprises? I don't think that the time to diagnose critical left main disease is with a catheter in the left main. We can diagnose these, not with perfect agreement with ICA for sure, but you really shouldn't be surprised too often if the diagnostic tool has been a CT, and I think we can help you and therefore inform cath in a different way, patient consent in a different way, perhaps a conversation with our surgical colleagues. And finally, what role does physiology play? Well, I think what we've seen is that, if I would have gone to John Webb again a decade ago and said, look, CT is a really cool tool, John. I think you should use it to help plan your intervention. We didn't yet have a mature understanding of fluoroscopic guidance. We didn't understand the lesion preparation thing quite as much. And what he would tell me is that, sure, CT helps me identify patients with an anatomical disease, but in complex CAD, it generally overestimates the syntax score. And that is true, right? If you have very complex calcified lesions, the anatomical syntax from CT is exaggerated compared to the invasive gold standard. But what Professor Soroyz and Carlos Collet showed us is that when they introduced physiology and anatomy, that the non-invasive functional syntax agreed quite well with the invasive gold standard, suggesting that there's an opportunity to provide an anatomical and functional roadmap that allows the interventionalist to go to the cath lab with an understanding not only of anatomy, but the physiology that results, thereby providing the interventionalist an opportunity to potentially plan her intervention. Here's an example, greater than 90% LAD lesion. We don't need physiology here. It needs to be stented. But there was a 70% mid-right lesion, and that was uncertain. As a result, what we see here, severely abnormal physiology in the LAD, negative physiology in the right. Instead of saying, good luck, figure it out, we can actually provide that roadmap such that our interventionalists can go with planned LAD revasc and deferral of the right. How about the phenotype of physiology? I think this is very important as we move forward. We've seen a lot from the invasive world, from IFR and also mechanized hyperemic pullback. This is from Professor De Bruyne and Carlos Collet, again from Alst, that the absolute value we know is important when the physiology is abnormal, but the path to the abnormal physiology is also important, right? What you have here is FFR pullbacks across the LAD. They all drop below 0.8. But the phenotype of the physiology is quite different. On the left, the pressure is normal, and it drops like a stone over a short distance. That patient and that lesion is very amenable to mechanical intervention. And I think that treating that lesion is likely to improve the physiology. Whereas the case on the right has very slow progressive pressure loss with abnormal distal tip physiology, but without a focal delta across any lesion. I'm not sure mechanical intervention is going to meaningfully make a difference. So we can generate similar imaging from CT, providing CAD endotypes beyond the anatomy to the physiology, the sort of rainbow pattern that we see on the left, very slow progressive pressure loss, abnormal physiology, abnormal vascular health, some risk of incident MI, but not necessarily treatable by focal mechanical intervention versus the two cases on the right with a much more focal delta, suggesting that those lesions are really restricting pressure and therefore may derive meaningful benefit from intervention. To that end, we looked at just a crude measure called the delta FFR CT, simply looking at the pressure proximal and 2 centimeters distal, and identified that when the delta was greater than 0.12 in the gray zone of physiology, it augmented the referral for invasive angiography as it related to the prediction of abnormal physiology and revasc. So just in a fairly crude and basic measure that anyone can do that augments our understanding and our decision-making, particularly in the gray zone of absolute physiology of 0.76 to 0.80. And here you can see a bit of an ugly figure to understand, but just highlighting that when you add that delta to the absolute value, it helps discriminate risk and benefit of revascularization and beyond. And the last area that I think needs exploration and obviously needs more evidence is the opportunity to not only plan PCI as it relates to those other elements, but perhaps in the future, no randomized data yet, but perhaps in the future, look at using not only baseline physiology, but an interactive planner which allows you to idealize the lumen and recalculate pressure to reassess the impact of revascularization on stenting. The idea here is that if you can calculate pressure with a stenosis, you can idealize the lumen and recalculate the pressure to have a better understanding of what your stenting will do as it relates to physiological pressure recovery. This is from Abdul again, a nice example of the FFRCT model, the planned revascularization, and the impact on nadir physiology. So this seems kind of sci-fi-ish and interesting, but is there any evidence to suggest this could work? Well, there is a diagnostic accuracy study that was published in JACC Imaging called P3. Here's such a case. This is invasive pre and post. You could see the pressure recovery from 0.81 to 0.9. This is modeled or computational pre and computational post, and similar results in this right coronary stenosis. So within P3, what did we find? We found that the agreement, sorry, this is probably not projecting that well, but essentially it was the study was powered to look at agreement between predicted post-PCI FFR-CT, virtually calculated, to measured post-PCI FFR. And here are a number of such cases where you can see the agreement was excellent. Obviously not every case showed excellent agreement, but overall it met the primary endpoint, at least providing us hypothesis-generating data that would suggest that this calculation of post-PCI FFR-CT may help us further understand which patients and which lesions may derive benefit from revascularization. So I'll stop there. I want to thank everyone again for the attention. There's so many more things we could talk about in CT, obviously as it relates to structural disease and beyond, but I really look forward to your questions, and I'm really grateful for the opportunity. Thank you. And I will tell you, and I again don't know if Dr. Kandzari remembers, but in 2004, when he was staff at Duke, we were looking at invasive angiograms and CT on 16-slice CT with Dr. Jollis, and I literally knew nothing. And Dr. Kandzari was very patient with me and taught me a lot then, so I have to give a shout out. I'm very honored and humbled to be here at this institution 20 years on, so thank you.
Here. Hey, Jonathan, good morning, and thanks for being with us, though. Welcome to Piedmont in Atlanta. So we're honored more so to have you here, too.
Thank you.
I do have two questions for you, and I found myself, just as an aside, wanting to start taking photographs of every slide here that you were showing. Well,
I'll send them to you even.
It was everything was so relevant for us, both from a clinical trials and practice perspective. And to that end, I have two questions, one clinical trials related, and specifically on the clinical experience side, based on the limitations of non-invasive stress testing, and in the United States, we're limited principally by reimbursement. But what role is there? When would you prefer a nuclear SPECT study rather than a CT angiogram?
Yeah, I mean, it's a good question. I think that if you have a patient with known disease, obviously stress testing plays an important role, although, my clinical colleagues in Vancouver would argue that a SPECT in those patients is very modest in its utility. As you know better than anyone, that many of those patients can't exercise, so we're talking about pharmacological SPECT. I think PET has a tremendous future, whether it's microvascular dysfunction and CFR, or also some of the valve work that we're looking at, sodium fluoride, understanding predictors of progression of aortic valve stenosis. I think that other, exercise-based stress testing will continue to play a role. I think we see stress echo being used in patients who are short of breath, where their coronary CT is non-contributive. They have very mild coronary disease, so, is it valvular disease? Do they have pulmonary hypertension? So I think it's really to answer other questions. I think if the question is, do they or do they not have coronary disease, I really don't see stress testing playing a meaningful competitive role in that upfront approach. I think it's in patients with known disease, when there's other ancillary questions around viability, as you know, of course. What does viability even mean post-revive? I don't know. But I think that's where I see it. And even in the ischemia trial, we have data that looks at the the prognostic utility of exercise beyond the CT, and we don't find that it adds anything to the anatomy from the CT, at least in the ischemia trial. So I think it's really to answer other questions. I think over time, hopefully reimbursement for CT from CMS will improve, and I think we'll just see a transition over time, not overnight, but a transition away from SPECT to CT as a first-line test. And the SPECT people can get mad at me for that, but I'm not naive enough to think in 20 years it's going to be CT. I mean, the field will evolve, right? So.
And then the other thing, going beyond that, those patients that already have stenting, the nuclear testing is clearly the way to go for a lot of these. But the other thing with HeartFlow now that they can do, if you have a stent in the right coronary, they can still do left analysis. So it's just one of those things that the technology continues to evolve. And I think we were supposed to touch on that. But yeah, it continues to evolve.
Thanks. Let me ask the second part, and then I'll step away. But the second is clinical trials related. You highlighted that you could have a high-risk nuclear stress test, and there's an 18% likelihood that everything could be okay, right? And fundamentally, this has been challenging for me for so long that our guidelines have been based on nuclear stress test results. And the ischemia trial for me in many ways is wholly impractical because sure, you have a high-risk stress test finding, but oh, by the way, we need you to do the CT angiogram first in 8% of the cases to find out that you have left main disease. So my question for you, I guess, moving forward is that in hindsight, would it have been better to do the ischemia trial just with CT angiography alone, or would that have been just repeating the COURAGE trial and of PCI versus medical therapy for disease? And secondly, do you see as we move forward in future major clinical trials like this, will there still be a role for non-invasive nuclear stress testing, or will we move to the standard being CT?
Yeah, it's a great question. I think, as you know, if you look at the evolution of the ischemia trial, a lot of it, as you know, emanated from Leslie Shaw's elegant analysis in circulation in the ischemia sub-study of COURAGE, showing there was a signal for ischemia-guided revasc reducing events. Of course, that was not redacted, but she published an important paper which our former colleague at Duke, who's the editor-in-chief of AHJ, but she published it. Published a study in AHJ in 2012 showing that actually when it was site read there was no, or when it was core lab read there was no signal at all. So the whole fundamentals of the trial were probably in question even as it was enrolling. I think you're spot on. I think the ischemia trial, what scares me the most about is when people conflate it to mean that it should be applied to all patients, when the average site enrolled 4 subjects, right? And that spontaneous MI was 52% lower in the PCI arm. And you poor interventionalists are having to recoil and not be able to say that spontaneous MI, friends, is the only MI associated with mortality. And peri-procedural MI, while important, is victim to the definition of that role. So, what I believe is that opportunity here is for thoughtful integration of CT to make informed decisions around medicine and appropriate revascularization. And I think if you and your colleagues take that anatomical and physiological or plaque data and really then inform your cath and really select the right patients and have a plan, I think that 55% reduction of spontaneous MI, which is something I would be awfully proud of, but yet somehow people ignore in the trial, I think you'll get that even higher. And then you're going to start to see that mortality reduction, maybe not at 3 years or 4 years, but over time. So I think this is a real opportunity to start doing things, better and more thoughtfully. And there is this P4 trial. It's not the size of the ischemia trial, but Carlos is leading that CT planned intervention versus IVUS guided intervention non-inferiority trial, which will provide some randomized evidence that a planned approach using non-invasive testing can be helpful.
This actually follows up on what David was talking about too. And on the Jorgensen slide, that's the only real slide you show that had a rubidium PET versus the CT. Number one, is that in the modern era where we measure the myocardial blood flow? And also this applies to that Dreesen area under curve slide too.
Yeah.
Does that include the modern era? And number two, in that the Jorgensen one, is that a head-to-head comparison, or
Yeah.
And then finally, do you think it's time for just some sort of national PET versus CT comparison, not for accuracy, but for downstream cost effectiveness and for MACE and all those other things?
Yeah,
That's a big question.
great question. So the first one, the Jorgensen paper is non-randomized. It's observational, but it's modern day use of rubidium PET, where rubidium PET was a first line test in Denmark. In a select centers. So it's obviously, well, I shouldn't say obviously, but it is quality. So it's, I think, important. But there's obviously confounders to your point, right? You don't know, why someone got a PET versus got a CT. So it was non-randomized. As it relates to the Pacific trial, that is actually core lab adjudicated, and that was water PET, with the core lab being Juhani Canuti. So I actually think that plays more into the hands of the CT FFRCT pathway, because FFRCT, while not perfect, is a number that can be obtained in a consistent way, in a reproducible way here at Piedmont and in Vancouver, whereas of course I can't get Juhani to read my oxygen label water PET. Well, I can't do that, but even if I could, he's not available to read all of our studies. As far as the cost effectiveness and the randomized trial, I personally see them as complementary tools. I mean, we're installing a PET. I'm so excited about the opportunities of PET to answer so many questions, but I can't see it as an upfront test being competitive, because when you think about it, and I'm sure here, when we do a CT, in this country right now, if you do a CT for CMS, you almost have to pay the patient to do the CT. It's such poor reimbursement, right? I think it's like $200 or something. I don't know how you even do it. But let's say they wisen up and they even say it's $400. $400, and you rule out coronary disease, or you find mild plaque, that patient needs nothing else but a medicine or nothing. Then there's about 30% of patients that may have mild disease. Those patients, so now we're at about 70% that need just the $400 test. Then you're left with 30% where you need to adjudicate physiology, and that's where you could do an additional downstream test or FFRCT, which will come in at an incremental cost of about $1,000, I think, in this country. So I think that 70% of the patients cost you $400 roughly. 30% will cost you $1,500. The blended average would be what? 45 would be somewhere around $600. Whereas a PET in this country right now for CMS is reimbursed about the equivalent of a house in Canada, right? I think you get paid like $3,200 US, only to find out that 60% of the patients have no plaque. So I think that's the problem. I think it'll be complementary though. I think that you'll, do the CT to really rule it out. And then if you have patients where you're worried about, microvascular disease or CFR, then I think really PET shines, and then all those other opportunities for PET. And then if it's more focal disease and planning intervention, I think lesion-specific measures will rule out, but I think that's obviously we need to continue to look at that. Such good questions, thank you.
Oh, sorry.
Yeah, please.
Just one quick comment. So I'm one of the interventional cardiologists, and I do a lot of physiology, and I struggle so much with this diffusely diseased LAD.
Yeah.
Right. And so I found that part of your presentation to be really compelling because, over my last year here at Piedmont, I've tortured all of my colleagues here with all of these sync vision models. And I don't know if you're familiar with the Philips sync vision, but essentially when you do an IFR pullbacking, you get a dot for every 0.01 drop off of pressure. And it's been incredibly humbling to me to see, okay, well, I can see this great spot for a stent proximally, and I'm going to leave behind 0.21 of ischemia throughout the vessel. So, I think as we're able, and I think most interventionalists in practice are not making these measurements. So we have no idea. So, when we find trials like Revive, when we find trials like ischemia, I have no idea what they mean because doing these measurements, we're leaving behind a dramatic amount of ischemia. I'm not saying that we need to solve it with stents, but I do wonder what is the value of a stent in these sort of vessels. So I think as we're able to understand the distribution of physiology across a vessel, I think really informs who I put a stent in and who I don't. And I think if we're able to extract that information before I go into a lab, because honestly, some of these vessels, you look at, you're like, well, it's not that bad, but I guess I'll just put a wire down it because, the PET or the nuke was abnormally. Like, damn, that's really bad. At the apex, the tip of the LAD, I have an IFR of 0.6, but there's no place to make an intervention. So, I'm continually humbled by the distribution of ischemia. And I think any sort of non-invasive test where we can say, okay, you're going to make a meaningful impact and you're going to be able to get this vessel to be non-ischemic with a stent, I think would be incredibly helpful at the bedside upstairs when I'm putting stents in these hearts.
I just feel like saying amen. Like, I wish you could, it was so thoughtful, and I think your points are so eloquently presented, and I'm so excited to hear that you see some opportunity, because you're the future, right? You're the future of how this can help. And to me, I'll just close with, it's exactly like TAVR versus SAVR. What we learned over time is that the surgical risk doesn't really predict outcomes in TAVR. It's the patient-specific anatomy on the CT. Are there hostile root features? Is the left main low? Is there subannular calcium? Well, the same thing here. And that's why, to your point, modern invasive imaging, but also going to the cath lab with a plan. You've gone totally unarmed, naked to the cath lab without any knowledge, and you guys still are making a real difference in quality of life and spontaneous MI. I think if you could go really understanding and selecting the patients, I think the sky's the limit. So I'm really grateful that you shared that, and I look forward to seeing your work in this space as you work with the team and continue to use CT.